I'm just going to share my screen and I've got some slides, so just bear with me while I do that. So hopefully you can all see my first slide. So I'm going to touch on the importance of outcomes and a little bit around what to measure. I'm head of pain for Connect Health, and I also work in a clinical trials unit at Keele University. So when we're talking about health and treatment related outcomes, it's quite a broad term and it can cover all sorts of things, including things like mortality, lab-based tests such as blood tests, blood pressure, weight. It can also include things like performance, physical function measures like timed up and go, as well as things like patient-reported experience measures. But we're focusing today, or at least I'm focusing on patient-reported outcome measures. And we're not talking about these kind of PROMs, unfortunately. We're not talking about the kind where you get all dressed up and go out with your friends, or the kind of BBC Philharmonic Orchestra version of PROMs. We're talking about patient-reported outcome measures. So the Patrick et al. Definition is a commonly used one, and it talks about PROMs as being a report coming directly from patients about how they feel or function in relation to a health condition or its therapy. And importantly, this is without interpretation by a health professional or anyone else. There are, of course, some exceptions or caveats to that, in that we do sometimes collect outcome data by proxy, where somebody lacks capacity, or perhaps for a very young child who might ask their parent to tell us their perception of the patient's, of their child's outcomes. So patient-reported outcome measures are tools or instruments used to capture information about patient-reported outcomes. And we're talking here about standardized and validated measures. And importantly as well, to be a PROM, there are 2 time points or more. So you're trying to see, has there been a change? And if so, which direction is that? And is it of a meaningful amount or statistically significant amount? So why collect PROMs? Well, lots of reasons why it's important to collect PROMs. So it can be really helpful as a clinician at an individual patient level. So it can help guide treatment. So for example, if we're collecting PROM data before a first assessment, then we've already got quite a lot of rich information about the patient we're going to be talking to. And it can help save time in terms of information gathering during the consultation. And it can also help us to focus on what matters most to our patient. It can help with clinical decision making in regard to things like diagnosis, trying to get a sense of what treatments might be indicated and the likely response to a particular treatment. We can also use PROM data to screen and stratify, and then to inform allocating patients to matched treatments. So moving from stepped care to stratified care. And it can help us to start thinking about, prioritization and goal settings, particularly when if we're using things like goal attainment scaling or patient specific functional scales and so forth. And it can help us to really try and personalize the care we're providing to the person we're working with. There's some evidence that PROMs can help improve shared decision making and communication, as well as patient outcomes, just the act of collecting PROMs. And of course, it can help communication between a patient and a healthcare provider. So we can talk about, what matters to them and the impact pain's having, and also talk about the effective treatment, to what extent it is or isn't helping them. It can also be a vehicle for communication between individuals within a team and between teams and services, particularly if the same core set of outcome measures are used throughout the patient journey. And of course, crucially, it can help us to evaluate how effective the treatment is that we're providing. At a group level, we can then pool this data, so we can look at individual clinicians or clinicians across a service or a type of group program, for example, and then we can have visibility of that data and things like dashboards. Can help at the kind of clinical and operational leads of a service to have some useful information about performance of that service or particular elements of it or treatments within it. can help with things like audit. And of course, it can also be really instrumental in quality improvement in terms of directing areas for quality improvement and then also evaluating and measuring the effectiveness of those efforts. So this quote here, benchmarking can provide comparative data to each pain service, can help identify best practice and clinical variation and drive quality improvements to setting aspirational targets for patient outcomes. So we want to obviously be able to understand where there's variation, is that warranted or unwarranted? And if it's unwarranted, how can we try and reduce that variation? As well as outcome measures, we're often also collecting demographic data. And that's really important to help us make sense of or understand our outcome data, so to contextualize the outcome data. But it also helps us to better understand the needs of our local patient group and identify if there are any health inequalities in terms of either access, provision, or clinical outcome. And it can also then help inform our understanding what resources might be required to address any health inequalities. So I've just put a couple of definitions there on the slides in case that's helpful for people when they look at these later. Of course, really important, as well as kind of randomized controlled trials and other forms of research, that we start to make sure that our service level data feeds into research. And there's great promise here around big data. So for example, in New Zealand and Australia, there's the Electronic Persistent Pain Outcomes Collaboration, and recently launched in the UK, this networking approach called the Advanced Pain Discovery Platform. So really trying to better understand what works best for whom and moving closer towards personalised care. So the information here from the EPOC website says the information collected by pain services provides valuable resource for research into the management of pain. And ultimately, of course, we would hope that this research would make its way into informing things like evidence-based guideline recommendations and also national healthcare policy and practice. In terms of the promise of the future, so excuse my pun there on the word prom, there's also potential for future developments to reduce the burden on patients, reduce assessment length, maximise response rates and increase the appropriateness of PROMS. So for example, there's something called item response theory, and this generates a tailored set of measures such as PROMS. So based on a patient's response to initial item, they then have visibility of subsequent items, and that's very much tailored to them depending on how they've responded to that initial item and perhaps subsequent items. And so that can really reduce the amount of time it takes and the burden. And then, of course, going forwards with artificial intelligence and machine learning and pattern recognition, we're starting to get a better understanding of what patients are likely to benefit from. So we can get information that tells us that patients who look like this tend to do well from this package of care, and that can help with decision making, so that patients are more likely to get something that's tailored and likely to be cost and clinically effective for them. PROMS are also required, recommended or incentivised. So for example, as a part of our services, when we're commissioned, often commissioners mandate reporting of PROMS as part of the standard key performance indicators. And increasingly commissioners are asking for evidence of PROMS when they think about who they're going to commission and around their contracting arrangements to ensure that this performance is managed. And we can use things like demographic and other baseline data to do something called case mix adjustment, which is where we take account for variables at baseline. So we make sure that if we're comparing service A with service B, that we're not comparing apples with pears. We have adjusted for differences in terms of patient need or complexity and so forth. But by doing this, it enables us to benchmark and compare services. And this is really helpful as well in terms of then looking at to what extent are we meeting any established minimal clinically important difference or reliable change scores compared to other services. And of course, it's also mandated as part of government agencies. So since 2009, services providing hip and knee replacements have had to submit PROM data relating to those procedures into a national database, and there's no reason to think that that won't in time spread to other conditions or types of treatments. And of course, they are very much recommended by accreditation bodies, professional societies, and so forth. So British Pain Society, NICE, Physiotherapy Pain Association themselves, in fact, produced a document some years ago led by George Peat, where we recommended some patient-reported outcome measures for use in pain services. So what should we measure? Well, that's the million-dollar question. And of course, it depends. It depends on the patient population, what is important for or to whom. So who are the stakeholders here? Is it the patients, the carers, the commissioners, service providers, other people? What does the treatment or approach or program you're providing aim or claim to change? Because presumably you'd at least want to be measuring some of that. And is there in fact an existing PROM that does that well, that measures that particular construct or domain? Who is the intended audience for the data? And what will it tell them, and what will they or you do with that information? So is it for commissioners? Is it for Healthwatch? Is it for your clinical colleagues? And is this data going to be a one-off snapshot? Is it going to be repeated for a 3-month period every year? Or is it on an ongoing basis? Because that will obviously tell us a little bit about the likely patient burden. And what about things like patient choice? So there are a number of documents, and I won't go through these because they'll be on the slides and on the website. But there are some sources of information you can look at where they've tried to come to some consensus around core outcome data sets that we should use perhaps in pain services. The last two papers here are specific to trials, so not so much clinical services, but they can still be worth looking at. And then there's some other documents and consensus statements and so on. This is not specific to pain, so these are just more broad in terms of general health measurement instruments. But whatever you look at, whichever document you look at, and we're thinking about pain, persistent pain, then there are very much common constructs or domains, whether it's the Scottish documentation or NHS England or whatever. They tend to all say we should be collecting PROM data relating to pain severity, health-related quality of life, emotional impact and emotional response to pain. So that can include cognitive and emotional elements of things like depression, fear avoidance, pain-related anxiety, and so forth. The functional impact construct or domain here is quite large, and it can cover all sorts of things, including mobility, activities of daily living, work, hobbies, social life, family life, sleep, participation, and so forth, and health utilisation and medication. And this, of course, is in addition often to other things that are recommended. So it's also recommended that we obtain information around diagnosis, anatomical pain site, pain duration, perhaps some process measures. So think about psychological processes, things like acceptance, patient-reported experience measures, as well as this kind of demographic and protected characteristics data that's really helpful to better understand the patient population that we're serving and benchmark and case mix adjust. So that's all I wanted to say, but really looking forward to the discussion later. So I shall stop sharing my screen and come back to the group. Thanks.
Thank you, Gail. That was loads there. I'm sure there's going to be some interesting questions that come up from that, but we'll hold that for the minute. We're going to hand over to Selina. Selina, are you there?
Yes. There we go. There we go. I'll just share my screen. Okay. Has that come up okay? People see that? Perfect.
Yeah.
So my name's Selina. I'm part of the PPA executive, but I'm also a pain physio at the Walton Centre. And what I'm going to discuss tonight is our experience with the recent changes that have been going on and how we've looked at our online pain management programmes and how that compares to our face-to-face. And hopefully from that, there'll be some common problems that I highlight, but also hopefully as well, we'll raise a few questions as to what we need to do in this area as well. So Pain management in an electronic and virtual world is something that's been on the horizon and in development for some time. And when I was looking to prepare for this presentation, I found this article that talked about the electronic and virtual working. But this article, if you look at the date, is 12 years ago. And it discusses all different types of technology and how they may offer promising solutions to the management of different chronic pain conditions. So it discusses things like electronic diaries, the use of social media, virtual reality, and online delivery of pain management programs and chronic pain treatments. It highlights that some of the advantages of these could be that we can actually collect outcomes in people's homes, and that's one way of reducing a bit of bias. It could also as well improve access for patients as well, so reduce some of those barriers to access that some patients have with attending our treatments. But they also highlight a few warnings, if you like, that there was little guidance out there on how to develop these virtual and electronic resources, and a caution that if unchecked, these e-health innovations may introduce new health inequalities, as well as solving some. And that's why the importance of outcome and measurement is really important. I think when I read through this article, lots of these things seemed things that maybe seemed a long way in the future for lots of us, maybe 3 years ago, particularly with the absence of IT skills and IT support to drive them forwards. But then obviously Omicron happened, COVID happened, and we had to stop treatments. And a lot of us feared that this was reducing access for patients to our treatments. I know I, as a clinician, and lots of you out there will have felt the same, the pressure to continue activity and services and not to abandon our patients. And a lot of our patients struggle anyway with social isolation and social withdrawal. So a lot of fears really, are those effects going to get worse in the confines of lockdown? And is this going to further increase suffering? And how is that going to impact on not only our patients, but actually our services when they resume as well? So in response, like probably everybody else who's on this, we began to think how best to deliver our services, as we really didn't want to abandon our patients, and we really wanted to think about how we could continue to deliver our pain management services. Like many other people, our pain management program involves different disciplines. So I've just put those in the Venn diagram. So we have physio, OT, psychology and medics. And like many other pain management programs, we also include the recommended components as recommended by the BPS guidelines. So what we knew is we had something that already worked well, but we couldn't deliver it in the same way. So we didn't really want to reinvent the wheel. We just really wanted to redesign it a little bit. In terms of sort of when we were looking at redesigning it, there were obviously some prominent issues that needed action, such as the technical challenges, concerns for us as clinicians getting used to this interface, but also as well preparing our patients for that interface and the need for orientation for clinicians and patients to get used to these things. We also needed different systems, and we've ended up using, for assessments, Attend Anywhere. For treatment, we deliver our treatment on Teams, and for outcome collection, we use a system called Qualtrics. So already we're using 3 different systems there to support our patients. Also as well, I'm sorry, my dog's just behind me growling a little bit. So if you hear a noise in the background, I've tried to shut him out. I do apologise, very unprofessional. But we also found when we were looking at outcomes as well, using some of the outcomes on the Qualtrics system, which is a system where we send patients an email and they complete the outcomes online. Actually, we couldn't use all the same outcome measures as we'd used before. There was some licensing restrictions there. So for example, like the depression inventory, we had to switch to the patient health questionnaire to measure depression, because the licensing restrictions wouldn't allow us to use that in a different way. So in terms of sort of our service and how we adapted it, we have the online program, which is 3 half days, free over 6 weeks. We had to reduce our group size, and in order to make sure that patients weren't fatigued online as well, obviously the number of hours that patients attend in a program have reduced as well. Our 16-day program was a lot more hours. Patients would come in for 4 days a week for the first 2 weeks, and then they come in for 2 days a week, 4 weeks after that. And since we developed it, what we wanted to do here as well was compare the outcomes between these programs. So we looked at a year's snapshot. So we looked at who'd attended our online program between August and September 2018 to 19, and then we compared that to who had attended our online program. And you can see straight away there the numbers are very disproportionate, aren't they? And I'll go into some of that and why that is. But what we did was we compared variables and outcomes that you can see here on the left of the screen. So these are our outcome measures that we use: pain distress, intensity, pain catastrophizing, a measure of depression, a measure of self-efficacy, a functional measure of sit to stand. We usually include timed walk. That does not work online. We can't get patients walking around their bedroom repeatedly. So we abandoned that measure, unfortunately, for the online. And then comparing our outcomes, we looked at to see whether there's a test of difference between them. And we looked at, we wanted to see specifically what effect these were having. So we looked at clinically significant change and also effect size. So I'm just trying to move my little screen away. Okay, so you can see here, in terms of referrals, pre-COVID and after COVID, we had, if not maybe a few more referrals to our pain management assessment clinic. But what you can really see here is those attending the pain management assessment clinic is a lot smaller. And you can see as well the numbers from referrals to attending the pain management assessment clinic there's quite a few patients there that are either screened out or choose not to attend as well. In terms of these patients here, these 489 that attended the pain management assessment clinic, what we can't really say is why that number is so much smaller. We assume that a lot of patients there, when they were presented with the option of an online compared to a face-to-face, opted out. But unfortunately, we didn't collect all of that data. And you can see as well, the full data sets we've got available are 177 for the online program and only 60 for, unfortunately, for our online program. We do know that that doesn't represent all the patients that attended. We had a much higher number of patients attending. What we did find was, unfortunately, when we started our online pain management program, the infrastructure we thought we had for collecting outcomes was severely flawed. So what we ended up doing was missing a lot of baseline outcomes. So what we're not seeing here is study attrition as such. What we're seeing is that the infrastructure wasn't in place to collect those baseline outcomes. We actually have more end of program outcomes. When we look at the differences between patients, so on an online program and a face-to-face program, some things that jump out here at sort of the demographics are that our online patients are quite a bit younger, maybe 10 years younger than the patients that traditionally attended the face-to-face, and a higher percentage are working. I don't think, thinking about the nature of the programs, that's too much of a surprise, but it's nice that the figures highlight that. And then if we look at the outcomes data here, what we can see, oops, sorry, skipped a long one. What we can see here is that both programs are achieving quite reasonable effect sizes and also quite high percentages of clinically significant change. And we see this for pain intensity and also pain distress. In terms of depression, obviously we were using different outcome measures for the online and the face-to-face one. But what we see is patients on the online program shifting from the high end of the moderate category to the bottom end of the moderate category. And again, comfortable effect sizes and clinically significant change. And for the BDI, patients shifted the categories mild to moderate, moderate to mild. In terms of pain catastrophizing, we see a reduction there and an improvement as well in pain self-efficacy. We also looked at the Canadian Occupational Performance Measure, which asks patients to rate activities that they think are important to them and rate them on performance and satisfaction. So you can see here as well, actually quite similar improvements for our online program compared to our face-to-face. And And also for sit to stand, actually what we saw on our online program was a slightly larger effect size and a slightly higher percentage of patients improving on that measure. Okay, and a few stars just to highlight that. When we asked patients about sort of how they felt in terms of their experience of the online program, about 81% of them said that they would be extremely likely to recommend this to a friend. But then we also asked them to qualitatively write down what they thought would be pros and cons of attending an online and a face-to-face. So obvious pros are that you don't have to travel into a program, that many patients felt quite relaxed and feeling less stressed doing things in their own home, and they found it easier to manage things around childcare, and travel as such wasn't a trigger for the pain. But you can also see in the cons, patients really felt in some ways that they've missed out on that social interaction, even though we did try in our program to build in group discussion sections, and we also had breakout rooms that they could go to in the break times to have little discussions, and they could post things on their chat together to try and keep that social interaction going. They also found the physio sessions, even though they had a reasonable benefit from the physio sessions and found them useful, a lot of people felt actually maybe they were missing out on something because they didn't maybe get that reassurance quite so quickly, or they didn't have that hands-on, that face-to-face component to reassure patients as well. So in summary of our results, like we said, patients were on average 10 years younger. The online program seemed to show comparable improvements for the face-to-face, but I think, and I should have made that but a lot bigger, I think it's a very big but. This is a very selective group. As you can see, only 30% of those referred actually attended and opted for the online program. So we've got a huge selection bias there from the patients. Pain intensity was less improved, but distress reduced more. And physical function seemed to improve, maybe even fractionally more. As we said, the advantages in terms of the practical, just move this bar as well. The advantages in terms of the practical and logistic benefits were highlighted by patients, but there's some there cons associated maybe with feeling that they've missed out on some of the clinical benefits, particularly around social interaction. I think a massive limitation is we have such a lot of missing data there, but what I want to use that to do is to highlight the importance of having outcome infrastructures to make sure that we've got high quality and complete data, so we can learn more about actually the outcomes that we're taking. So how do we compare to what was out there? Well, having a little bit of a look at the literature, we wanted to compare to what was out there. And I found a nice systematic review here that shows 8 studies that highlighted 8 studies that used virtual programs. And this is by Booth et al. And what they highlighted is that none of the included studies conclude all the BPS core recommended components of a pain management program. Jackie Walumbi et al. Also did a rapid review looking at video conferencing, and they identified 3 studies, and they said they were all quite low quality with high risk of bias, but highlight that there's really a lot of mixed formats in terms of sort of program delivery, and little guidance on how to develop programs, and give some really nice sort of food for thought and considerations there, and highlight the importance of systems to capture clinical outcomes. And then this other paper here by Williams et al. Describes the development of an online pain management program, and it's a really lovely descriptive piece describing sort of all the things that people need to think about in terms of developing a pain management program. They don't describe the outcomes, and they only had 16 patients, but I'm sure that's on its way, their outcome description there. And similarly, they report that there was a lower number of their patients opting for the online pain management program than the face-to-face. So I think what these all show is the importance of how programs are being developed and making sure that, you know, under the pressures of what we've had to do quite recently, is making sure that as we develop things, that they include the best practice guidelines. But also with this rapid expansion in online services, there is a real need for hard outcomes so that we can evaluate how these work and compare them to face-to-face ones as well, and see how both can be aligned. So looking at the results, what don't we still know? Well, it seems that online programs do seem to have quite good outcomes, but do they suit everybody? What we've identified and what the Williams paper identified, there is a large proportion of patients opt out. However, whether this will change with time as patients get used to these, and clinicians as well get used to these sort of interfaces, and get used to the familiarity and better socialise with online things, we may see that reduces. I think a big important question is, how do we best select for face-to-face or online? And in order to answer that, I think we need to understand the barriers and facilitators for online versus face-to-face formats. And that needs to include both patient and clinicians' perspectives. I think as well, you know, thinking about what we are, what additional questions do we need to ask? What are we missing here? What do we need to include with this? And we obviously need longer term data as well to see whether the effects of an online program are maintained in the long term. I think we do see improvements, but are there also inequalities in terms of being able to access things? You know, what about our vulnerable groups, like low social economic groups? Are they able to access these online resources? And how do we, is that in part why we're seeing such a high opt-out rate as well? And I think that maybe needs a little bit more further explanation. So in summary, what people need is obviously always different and not one size fits all. But bringing the pain management programs into someone's home presents a really unique opportunity. And I think as we've seen a rapid expansion in doing that, and hopefully what we're going to see is results that support the efficacy of those treatments, there is going to be that justification for online pain management programs. But as we can see, many patients maybe would not choose it or are not choosing online pain management programs. Whether that changes with time, we'll have to wait and see. But it's likely that the results are going to show that online programs should remain, which is going to lead it to more hybrid working. And if that's the case, then it's not a replacement for face-to-face, but we need to consider who suits what program and how we select people. And I think that really brings home sort of like the importance of really careful selection and screening, and whether that includes our PROMS, as Gail mentioned, to help better stratify patients, whether there are things there like machine learning that can help us predict when we've got that outcome data behind us, who goes where and who's likely to benefit from what we still don't know. And that's why those outcomes are needed to support the development of this. And also, as I've highlighted, by the big gaps in our evidence, systems in order to capture the clinical outcomes and make sure that things aren't being missed as well. So I just want to say thank you to everybody who did the hard work on collecting the outcome data, which wasn't me, but we can see there Katie and Alison and Gina and Nat and Kerry and John. Okay, thank you. And I'll stop sharing my screen and hand back to Claire.
Thank you, Selina. That was quite sobering, really, to hear how much has been achieved and so much change over the last few years. And also kind of reassuring that the similar questions that we're all asking, we're all looking at from the same angles. And I think that's really going to lead to some interesting ways to move forward in the future. So thank you. There was a huge amount in that presentation. I really enjoyed that. I'm going to hand over to Leila. Leila, are you there?
Yep, I'm ready.
Great.
Okay, so I'm going to, actually I should introduce myself. I'm Leila. I work in Oxford in a pain rehabilitation service, which is multidisciplinary. And I'm going to do a presentation in 3 parts. The first part of which I'm going to present some data from our service related to clinically meaningful outcomes. Then I'm going to talk about the opportunity that COVID has brought in terms of digital PROMS collection. And lastly, I'm going to think about whether we're measuring what we need to be measuring So just to give you an idea of the service so that you can understand, sort of link that up with the data I'm presenting, we offered a range of services pre-COVID, and in fact, we're back to this now. The majority of our patients are choosing to come back face-to-face, but we do still run some digital programs. So we offer what you might say is a standard pain management program, 38 hours, which is an acceptance and commitment based type program. But we also have a compassion for pain group, which is interdisciplinary, and that's 8 lots of 2 hours. We have a physiotherapist-led program, which is a sort of combined physical and psychological program using psychologically informed physiotherapy, which is 45 hours in duration, and exercise hydrotherapy classes, as well as individual treatments with physiotherapists and psychologists. So did an audit, and this is a little bit historic now, so going back to around 2016, of 221 patients with chronic or persistent musculoskeletal pain. Physiotherapists undertake the initial assessments in our service because historically it was a physio-led unit. And following this assessment, we use a kind of selection guide, which is partly based on things like walking ability and questionnaires. It's partly clinical reasoning, but it's also about other factors as well, which I don't really have time to go into at the moment. We selected 112 patients for pain management programs and 109 for the physio-led program, and looked at effect sizes and clinically meaningful changes in depression and brief pain inventory interference scale. So this is just an example of some of our measures. I'm sure I'm speaking to a pain audience, so I'm sure you're familiar with these. So we looked at anxiety, depression, the brief pain inventory, which can be considered a functional score, and acceptance as we're delivering an ACT-based program. So firstly, in terms of depression, if looking at the literature, a 6-point individual change could be considered as clinically meaningful, but often in IACT type services, they use a 5-point change. And you may be familiar that in IACT, they often measure every single treatment session. And you can see from this that 40% of people in the physio-led program achieved a 6-point change, and 33% in the pain management program. So a little bit lower for both the 5 and the 6-point change in the pain management program. And maybe that's unsurprising given the enduring and long-term nature of pain. And also I think because we in our service run these 2 programs, only the more severe type patients tend to access the pain management program rather than having a broader spread of patients entering the programs. And then in terms of clinically meaningful changes in the brief pain inventory, there's not huge amounts of data published in this area, but Thorne and Morley looked at clinically meaningful changes where they compared the change in the interference scale with patients' global rating of improvement. And they determined that a 1.6 reduction was clinically meaningful. The impact recommendations and the Dr. Foster pain audit suggested that a 1-point reduction was meaningful. If you, as a sort of rough guide for research, you might consider 0.5 of 1 standard deviation of your population as being a meaningful change. And so for our population, that would be 1 point. And again, you can see that in the physio-led program, again, slightly more people achieved that 1.6 reduction. And I don't know if you find that surprising at all, but we're really looking at, you know, between 40–60% of people achieving these sort of changes, which a 1-point reduction as well doesn't sound too much to me. And then we use a shuttle walk test on the physiotherapy led program, which has been validated in chronic low back pain. But there's not a huge amount of data, again, for clinically meaningful changes in this shuttle walk test. So these are, I've just taken two figures from published papers. And again, looking there, we're looking at 35% for this 76 metre change, but bear in mind that this is a speed test, so it gets faster and faster as you go on. So that 76 metres would be quite difficult to achieve, but that was what was rated as clinically meaningful in the patients with lumbar spine pain. So moving on now to another audit, and this was where just looked at patients who'd attended an interdisciplinary pain management programme. They'd completed a battery of questionnaires, pre-treatment and at 3 months follow-up. The previous data was also from 3 month follow-up. And we calculated the percentage of patients that have self-reported an improvement on the global impression of change score. And we took an improvement to be 4 or more. It's a 7-point Likert scale. And then we looked within that improved group to look at the mean change on the brief pain inventory interference scale. And then we looked at effect sizes for the total cohort compared to the improved cohort. And you can see here that if we start with the red, which is the complete cohort, the effect sizes at 3 month follow-up, which when we're thinking about effect sizes for rehabilitation, 0.5 would be considered moderate, 0.9 or above, or 0.8 or above would be large. Now, if we're thinking about randomized controlled trials, usually where you're comparing two groups, the effect sizes are generally lower, about 0.2, 0.4. So compared to this, they seem quite reasonable. We would expect them to be a little bit higher because it's just one cohort. But then if we look at the improved people who had self-reported an improvement post-treatment, actually the effect sizes there are higher again. So, and also you can see that again, it was about 48% of people who reported that they felt that they had improved. And this data was just from complete data sets that we had from pre-treatment to 3 month follow-up. So that's probably about 60% of the patients that were attending the service, and this was pre-pandemic. So I also forgot to mention that the mean change within the total cohort was 1.6. So it did mirror this change that seems to be acceptable to patients, but just slightly less than 50% of patients considered these changes to be an improvement. And it just makes me wonder whether we need to reconsider the estimates of a minimally important change, at least if we're using the BPI. And also, do we need to think a little bit more about exploring patients' expectations before treatment to think about what their likely benefits might be? But the other part of this is there may be things that we're not capturing in these measures, which I'll touch on later. So moving on now to talk about digital PROMS collection. So in our service, as a result of the pandemic, we had the opportunity to start using some software, and the designers were from Oxford University, and they developed this in a bespoke way just specifically for our service. So originally it had been developed for use for orthopedic surgeons. And what you can see on this screen is the home screen. So we can search up a patient, and then we can press these buttons to get different screens. So at the beginning, we might press on treatment and select what type of treatment the patient is going to have. We can look and see what happens is this email is, an email is sent to the patient before treatment, and they complete their PROMS online before they come to clinic, whether it's a virtual appointment or face-to-face. If they haven't looked at it, we can see that they haven't looked at it, or we can see if they've completed it. And we can also send another email to them there and then in clinic so that they can redo their questionnaires, because some of the problems we found with this is that these emails are going into junk boxes, or they're just getting lost amongst other email traffic. There's a patient screen, which I'll come on to in a minute, and this you can see is the clinician kind of basic screen. So you can see that sites of pain are reported. We also have certain questions highlighted. So we have question 9 from the PHQ-9, so that we have a bit of an idea about whether we need to do a suicide risk assessment or talk about suicidal ideation in the assessment, also whether they are experiencing a lot of fatigue. And you can see here there's quite a large battery of questionnaires, and you can also notice that they're different from the ones that Selina has mentioned, and that is also part of the issue nationally, is we're all collecting different things. So what I'm currently doing is some qualitative research to ask patients about how they find this process with undertaking digital PROMS collection, because it takes them about a good 20 minutes to go through, although they can pause and come back to it where they've got up to, which is quite a good feature of this software. I'm also asking them a little bit about whether what we're measuring is measuring what's important to them. The other part of this is that we have a consent form, just to say that patients consent to having their information on the database, but they don't have to, then it will just go in their notes. And we also have this section called information prescription, which I'll come on to later. The whole piece of software has undergone a data protection impact assessment, so that we know that it adheres to GDPR and information governance policy for the trust. So this screen is the patient view, and we can, or we may choose not to use it. It was originally developed like this because, for example, if you're an orthopedic surgeon using the Oxford knee score, there's a lot of data so that they know if you're a certain score on the Oxford knee pre-surgery, they can predict what your likely outcome is likely to be, and discuss that with the patient in clinics to inform their decision on whether they want surgery. So you can see on this average pain area here, this is data for our whole service. This is thousands of baseline data that we've got here now. And this particular patient is scoring 7, so near to average for service users. And this is also showing other, it will go through every PROM, and if we wished, we could show patients where they're scoring in comparison to the rest of the service. And in the future, what we could do is also use this as a post-treatment screen that we could show to patients. However, you can imagine that if you have a patient who is scoring over here, they may not necessarily want to see that, and also presenting this type of graph to a patient isn't exactly very patient friendly. So that's another thing that might come out of the research. This screen is the information prescription screen. And so if we want to select a leaflet, we can just click on send. It will show the date that it's sent and when it's been viewed. So that's quite helpful. And we also have meditations that we can send out and recorded presentations, so that when patients are coming onto a pain management program, we can also send them meditations to listen to at home, or if they're on the virtual program, we can send things to them. But we've already had some feedback from when we did some satisfaction work about the virtual programs, to say that actually they weren't that keen on electronic resources, and they would prefer hard copies, which is quite interesting. The other thing that this software will do is it's an automated method of PROMS collection. So 3 months post-treatment, it will just send out an email, and that saves us a lot of time because it's just being done for us in the background. And the other thing it does is that every week after the pain management program is it sends an email with some information as a sort of booster information to patients to remind them of things that they have been taught during the pain management program, or that they've picked up in their time there. And this is just to show you just a little bit of an idea about things that we can send. So we can send patients guides on how to use Microsoft Teams if they're doing a virtual program, and this is a sort of illustration of the virtual manual content that they receive. But are we measuring what really matters? And this is quite an interesting paper, which brings up some interesting points about suffering and pain-related suffering by Peter Stillwell and colleagues. And he included a patient advocate in the authorship team. And what he argues is that there is potential value in actually developing some valid measurements of pain-related suffering. And the numeric rating scales that we use, particularly around pain, don't convey the nature, meaning, or the cause of pain-related suffering. So they're not picking up some really important information. He suggests that qualitative research is needed to develop interview guides which might help us recognise and validate suffering. And we know that when validation occurs, that is a very important feature of developing a therapeutic alliance. And when there's a better therapeutic alliance, we know that that also is related to better outcomes, particularly in musculoskeletal services. He also suggests that we could do more to explore effective themes linked to bodily and cognitive processes if we started to think a little bit more about what pain-related suffering is. And then this paper was looking, it sent a survey to healthcare professionals and also patients, and kind of using the impact research recommended guide outcomes core data set, if you like, as a basis, but asking both clinicians and patients what they felt was important to capture from in outcome measures for people with chronic pain. And some of these things here were items that patient identified, which were outside of actually what the final recommendations were. And their suggestion was that these things are not really being captured or asked about in clinical services. And you can see from the questionnaires that we've been talking about today, there's nothing in there about sexual function, social isolation, or companionship, although I know some services do include that in their PROMS data. And also, one of the things they wanted to know was about the quality of support that they'd received from the pain service that they'd attended, and the quality of education and information. And then some of you may be familiar with this paper, which is by Francine Toy and colleagues. And this was a qualitative synthesis of 190 studies, and looking specifically about what features helped people feel that they had healed when they were living with long-term pain. And again, many of you will be familiar with Joletta Belton, so a patient representative was included in the authorship team again. And these were some of the 4 themes related to healing, which I'm just going to touch on a little bit. I've just picked out a few quotes, there were more. But one of the things was that in terms of reconnecting the world, a fellowship where someone described attending a pain management program helped them to no longer feel alone. There was also something around humanity in healthcare, where there was a sense of being respected as a service user, and this fostered a sense of feeling safe. There's reconnection with the self, so this sense of being kinder to myself. I put the picture in the Peter Stillwell slide of a couple sitting on a bench, because one of my patients said that she used to push herself until she was in tears in the allotment, but now she would stop after when she'd had enough and sit down with her husband and have a beer, and she said it just massively improved the quality of that experience. And that's an illustration of how when people start to perhaps develop more self-compassion, they can then perhaps exercise better self-care. And the other important thing about self-compassion is that if we're using mindfulness strategies, it's a way of perhaps a first step is using self-compassion before exposing yourself with mindfulness to some unwanted or difficult thoughts, feelings, and sensations. The other part of this was an integration of mind, body, and self. And again, that might be something to think about, how we might measure or ask about that. The validation of pain, again, came up as really, really important. One person said that being validated in a healthcare service just changed their life. And that sense of validation probably also comes from group work. And lastly, a sense of a future, being open to possibilities, an ongoing journey home. So for the future, I wonder whether we will develop a new outcome measure that captures more of these profound, really meaningful outcomes for patients.
Thank you, Leila. That's very exciting, all the work that you've done there, and a lot of food for thought for where we go in the future. And I think that's very exciting. I'm going to hand over to Dermot for the final presentation. You there, Dermot? Can't see your screen.
Can you hear me now?
Yep.
Hi, sorry about that. My Zoom decided to suddenly stop responding. Can you see my slide?
Yes, can see that now.
Phew, that's great timing, isn't it? Thanks, everybody. Yeah, so by means of introduction, I am Dermot Dennehy. I am the co-chair now of the PPA. I am the lead physio at UCLH in a large multidisciplinary pain centre. I'm also currently doing part-time my PhD as an ESRC fellow. I'm a member of the Footsteps Organising Committee. I'm a member of the Global Alliance for Partners for Pain Advocacy, which is an IASP task force. I'm a member of Live Well with Pain, and I also do some consultancy work with Levitt Clinic. I really should quit some of these, I think, looking at this list. But anyway, just and I was a member of the NICE Chronic Pain NG 193 guidelines. So just to give you a sense of who I am, I receive my main salary from UCLH, and I've received monies from Levitt Clinic, and my stipend from my fellowship, but otherwise they're voluntary roles. So just for full disclosures. I'm starting here a niche reference to Jennifer Aniston's shampoo ads here, you know, where she says, and now the sciencey bit, I'm going to go, and now the less sciencey bit, having had 3 excellent presentations from Gail, Selina and Leila. I feel slightly like I have imposter syndrome, and I come here not as an expert in wearable technology, and to prove that you need to ask my 14-year-old son, who will confirm that vigorously. So I just wanted to stress that, you know, when I'm talking here, we're talking about outcome measures rather than wearable tech such as exoskeletons for you know, gait support or virtual reality therapy. So we're thinking more about outcome measures rather than therapeutic use, although I appreciate there's a somewhat grey area between the two. So having heard from Gail and Selina and Leila, and just thinking about, you know, I think we're all fairly comfortable with the idea of PROMS now, so why would we change? And I suppose I'm putting a counter here that, you know, there's well-recognized biases, if you like, in terms of completing PROMS. And so for those reasons, we kind of want to think about what other ways can we collect outcome measures from people that aren't reliant perhaps on memory and subject to the bias of cognitive or social desirability or other biases that may be present when people are completing these outcome measures that we ask them to complete. And this all came about when I did a talk with Professor Amanda Williams at the British Pain Society Pain Management SIG in Glasgow in 2018, I guess, so quite a while ago now, where we were talking about outcome measures at that, funnily enough, and I was asked to kind of think about objective measures, and these recommendations had come out from IMPACT, which has already been mentioned, but also OMERACT, which I guess is the Rheumatological Association's equivalent of IMPACT, in terms of what outcomes should we be collecting? And they broadly, this is a very busy slide, I apologize, but they had 7 key recommendations that when we're thinking about what physical activity or function measures we're collecting, we should really be thinking about that, having developed it from a conceptual framework. So whether that's, you know, behavior change theory or social cognitive theory or whatever it is, that we should be thinking about our what measures we're going to use in those terms, that we're not just plucking things out of the air because we're told, but thinking about why are they relevant? You know, what's the theory underpinning why these might be useful for us? Really, point 2 is the big one. We should be including the people we work with when we're thinking about measures. And I know that's been mentioned several times, from, you know, Gail's shared decision making through to what Leila was saying, you know, about meaningful measures. So you can look at this in more time because I'm conscious of the time and we would like to have time to talk at the end. So we'll look at the recording and pause to see these. But that led us, myself and Amanda, to write a paper for the PPA's good old Pain Rehabilitation Journal, which you should all read if you haven't already. But in that, we kind of looked at, we did a rapid review and identified 15 studies and just compared what they were reporting. So bear in mind, this is research rather than necessarily our clinical practice, but I think there, again, are lots of parallels and overlap. And we kind of mapped what they reported to what was recommended and found that broadly, research is quite good where they use automated functional data collection. So that's the term you'll often see for wearable tech, is automated functional data collection, as opposed to PROMS, which we've mentioned, and then CROMS, which are clinician-related outcome measure or clinician-reported outcome measures. So your sit to stand or your timed up and go might be considered a CROM measure. So these are automated, where we're using, whether it's a pedometer or an actigraph or something like that, to collect data automatically. And really what's really striking here is that none of the studies involved patients in deciding what they were going to capture or how. And that was granted, that was in 2018, but you know, what's changed since then? Well, as part of thinking about this talk, I did a quick and dirty search of the literature. I used the Impact and OMER Act recommendations to see who had cited them and tried to pick up the most recent one just to get a sense. And it probably comes as no surprise that really not a lot has changed since then. And actually, it's difficult to get a sense of how much we are collecting automated functional data clinically, because obviously that tends to be less reported, and we'll only see what's being used in the research, but really very little has changed. They use this term, which I thought I'd mention, ecological momentary assessment. And really, when you look at what that means, it's more about collecting contextualized data from people. So often, you know, there might be a beep and a reminder on their phone, and then they'll be asked to input then where they are in their own environment, rather than often when we collect PROMS, it might be that the person has come into our center and therefore it's not in their home context. Using automated functional data or kind of wearables is not new. This paper is nearly as old as I am, back from 1977, talked about the use of pedometry and actimeters. Funnily enough, they talk about activity in man. When you look at this paper, it's actually looking at measuring physical activity in children. But anyway, hey ho, what's a title? So it's not new, but it's still interesting how perhaps little we've moved on. And separately, the PPA, we've done a lot of work with Professor Frank Keefe, and I think one thing I've taken from Frank is he tends to stress that we should be doing the basics well. And often that means, you know, stepping back from perhaps sexy ideas about what wearable tech might involve. I know when I looked into this first, you know, we might see that actually the direction of travel is, for example, with spinal cord stimulation, that they may in the near future contain sensors to capture movement and things like that that could be used as automated data collection. It's also used in pacemakers. So, you know, that starts to make us think of all sorts of potential and applications and how we might capture data. And it's been mentioned about, you know, AI and machine learning to help us to understand more about what's going to help people. You may have come across this guy. My wife actually introduced me to him. She saw him speak. His name is Neil Harbison. He's a Northern Irish Spanish cyborg. He's the first legally recognized cyborg where he had an implant. And this implant directly into his brain responds to things like light and Wi-Fi and things like that. Now, this may be the future of travel, but where are we now and what could we start with now? Because we're unlikely to be implanting things and turning our patients or requesting our patients become cyborgs to work with them, I'm sure. So, if we come back to pedometry, as I said, it's not new. It's been around for a long time. Good old Kath and Kim here demonstrating how pedometry might be used. But really, is that the people you work with? Is this something we definitely want to capture? Pedometry, is that meaningful? Is it relevant? Is it related to their goals? If somebody's got upper limb pain, will it be useful to capture the number of steps they do? There's all sorts of questions we need to ask ourselves. And actigraphy is used a lot in the literature. And I think this will change as obviously technology has improved, but it's what you'll come across a lot when you're looking at physical activity measurement using automated data. And what actigraphy can tell us over and above pedometry, I guess, is that it measures body position, also times of rest, as well as activity. And again, if you think about our population, sometimes we're not wanting people necessarily to do more. We might be wanting to encourage them to pace and take breaks. So it can be really useful information if we're able to capture that. And if we look at some of the more modern, like this is a Fitbit kind of homepage, that the capability is there now with most technology that many of our patients use already to get a sense of, what they're doing over a day. This is a screenshot from a Garmin, which very neatly, looking at step count, can give you a sense over a day of what people are doing. So there are crude ways that we can start to get a sense of, people's activity patterns, because that might be more of relevance to us than actually the number of steps they do in the day. But there are all sorts of other ones. This picture is small, but and again, I'm finding pictures of these are hard to find because the technology continues to improve rapidly. But this is looking at galvanic skin responses. So perhaps a proxy measure for stress responses. That may be something that's relevant. And if we go back to the Impact and OMERACT recommendations, kind of they talk about making sure we think about measures that are relevant. And although we might think about physical activity, we could be thinking about other things like stress response or breathing patterns. Could be something that might be relevant depending on the work you're doing with somebody. Or, blood pressure might be something relevant, or even sleep. Leila mentioned how, consistently sleep is one of the highest rated issues that people who live with pain report, but it gets very often very under measured or kind of considered, certainly in lots of treatment programs and things like that. So it's definitely something we should be considering. There is a caution, however, again, when we're thinking about these, it's always a balance between helping to provide useful information versus perhaps feeding into what might be sometimes termed hypervigilance, for example. So it's thinking about, that balance and kind of being mindful and aware of that, ensuring that if we are looking at or recommending somebody use this technology, that actually is going to be in a way that's most helpful for them, to help them towards what matters to them, rather than just to collect another bit of data. We've talked a lot, Selina mentioned it, the importance of infrastructure, and in our trust in 2019, so maybe a blessing in disguise, but we moved to using Epic, which is primarily an American digital healthcare system. But it meant we moved from using about 5 or 6 different systems in my trust to just having everything in one place. And perhaps one of the potential benefits of this is it allows us to plug in and capture or, automatically add in some of this automated data, for example, step count. Now ignore physio measures and then just different types of walking aids. There is lots we would like to change with Epic, but as a starting point, it has potential. And part of the work we have done as a quality improvement project over the last year or so is around, one, helping our patients to access or to set up accounts, because they can set up their own account on this system, with the intention of then helping them to use it to complete their questionnaires digitally. Part of that work required us to look at the battery of measures we capture, which are similar, but again, nuanced and different to what Selina, what Gail, what Leila also showed in their centres. And so, for example, we worked on the burden of capturing these to try and reduce it as much as possible, whilst also collecting what's recommended by the British Pain Society and Impact, for example, recommendations. So, for example, we switched the PSEQ from the 6 version to the 2 version. We did similar with the PHQ-9 down to the PHQ-2. So looking at, are there shorter versions available that we can use? We would use those as our preference. It was interesting hearing Selina talk about, you know, having to stop using the timed or the walking test. We found that when we started running our programs in hotels, we had to stop that then anyway, because you rarely got a space that wasn't a public space to ask people to walk in the, you know, 10 meters for a period of time. So we did a piece of work at that time looking at how well correlated the walking test is timed up and go on the sit to stand or, and that allowed us to decide we were just going to use the sit to stand for that reason. And fortunately that has worked reasonably well even with our remote programs. That infrastructure is key, and that's something that we've used. And I had hoped when we were talking about running this, we had last year started to set the wheels in motion to look at a service kind of improvement where we're going to provide our patients with a kit box, which is going to include a relatively cheap type Fitbit. Other brands are available. It's not a Fitbit, but a cheaper version does similar things, along with a patient information sheet, not this exact one, that's just one off the internet, but an information sheet to explain what it is we're collecting, why, how the data will be stored, you know, all the things they will need to know to make a decision to try this out. It will include links to an app that we will have, a specific app which will include collecting this automated data along with a selection of our PROMS, because part of the Impact and OMER Act recommendations are that we should be collecting both together, not just switching to collecting only automated data, that there is still, as you've heard from everybody else, value in the PROMS that we can collect. But also to be able to offer, our trust has got a tech buddy team who can, you know, speak to people, walk them through how they might set up the app for those who may be less confident or less digitally literate. And our intention is that the project is going to look at one of our physio activity groups. It's a 10-week program, an hour a week, where we explore different types of movement. And we want to be able to check how automated data might compare with the PROMS that we're gathering for this population, because currently we're not doing that. Unfortunately, Omicron and things like that meant we have delayed our start, so it hasn't started yet, but we're hoping to start in the summer, so I can't provide any data for you on that, but it's just to give you a sense of what we're planning to do. And we're hoping to use, this is single case methods. This was, there was a whole workshop on this at the EFIC conference 2 weeks ago in Dublin, but I'd highly recommend this book by the late great Stephen Morley on single case methods, which basically encourages us to, you know, where we are in clinical situations where it's not particularly easy necessarily to do formal research or, you know, a clinical trial or randomized controlled trials, that maybe we could consider single case methods, which you know, in a really sweeping introduction here, encourage us to collect baseline data over a period of time to get a sense of where people are at now before we then do our intervention, which might be our physiotherapy treatment. And then we continue to capture the data at specified time points and just see what change there may be. So it's a really, I think, nice way to systematize how we're collecting data. You know, we could do it as part of just our practice, but the challenge will be, how do we collect the baseline data, you know, to see what the change is. So that's maybe something that we would need to think about, because for our centre, unfortunately, we do have waiting times when people are referred to when they actually get their first appointment. So our intention is during that period to collect the baseline data whilst they're waiting anyway, and then we'll have that as part of this process to kind of measure what we're doing. Some just general tips from my experience with this is we really need to think about the purpose. And I don't need to say too much about this because it's come up very clearly with Selina and Gail and Leila's talks. But why are we collecting what we're collecting, and how would we capture baseline data? There are things to consider. Really important is about co-establishing, working with your patient, if it's one-to-one, around what might be the most valuable data? Do they already use step count? Do they already use some other kind of Fitbit or Garmin or whatever it might be? And could you use some of that to explore their, an outcome measure for them in terms of what matters to them? Support, I mentioned we have tech buddies that can support patients when needed, but it might be we're also providing the pack for people because they may not have access to a wearable tech device themselves, but also support for us. One of the key learnings for us, partly with the implementation of our Epic system, partly with COVID and switching to digital delivery of services, was developing links with our tech support and our innovation lead and our trust. And that's really key. And I'd highly recommend that if this is something you would like to develop further wherever you work. Simplicity is key, less is more. Again, we're not trying to, make cyborgize people. Is that even a word? Well, it is now. And what I hoped we might have time to think about in the final part of tonight was, is there anything you would add? What, if you're already, I'm sure many of you are already using perhaps automated functional data, whether it's a pedometer or something else. It'd be really keen, even if you could put it in the chat if you don't have time in the discussion to share what you're doing, as well as what might the challenges be. I've put my hands up. This is something I was interested in 5 years ago, and it's only now we're starting to do something. These things take time. It's a slow process. We have to be patient, but what might be getting in our way of doing this? Because it's going to come. We're all going to be collecting more and more of this as we progress through our careers. So thanks everybody for your time. I'm conscious of the time, so I will stop talking and hand back to, I guess, everybody now for a bit of a discussion.
Thank you, Dermot. There was a huge amount in that, what you were saying on doing the basics well, keeping things meaningful and relevant. And thank you for sharing.